Hello, we're going to focus on the spinal cord, spinal nerves, and spinal reflexes. Now, for some of you, you probably are familiar with the spinal cord per se as part of the central nervous system. You may also have some familiarity, but not detailed familiarity, with the spinal nerves. And it's very important to understand the spinal reflexes because they can tell you a lot about the present state of the central nervous system and what is actually going on in the patient. Well, let's explore this further. And here we go. When I talk about the spinal cord functions, they basically work independently from the brain. Central nervous system includes both brain and spinal cord, as we've said. You have a sensory input, which is carried by spinal nerves. These are the afferent pathways to the CNS. Reflex centers in the spinal cord coordinate responses from that sensory input. Okay, so we're going to have some sort of motor output eventually. Now, a reflex is a rapid automatic response triggered by a specific stimuli. Spinal reflexes are controlled by the spinal cord, and they can function without any input from the brain. Now, if we take a look at this diagram here, we see where in chapter 12, we're going to explore the spinal cord independent of the brain. The brain's cranial nerves and sensory and motor pathways, that's all going to be chapter 13. That's already in the recorded. Here, what we're going to do is look at the sensory input from the spinal nerves, the reflex centers in the spinal cord, and then the subsequent motor output over these spinal nerves. Now, you got to keep in mind that the effectors are going to be muscles, whether that's skeletal, smooth, or cardiac muscles, as well as glands, and in some cases, adipose tissue. The spinal cord has 31 segments with 31 pairs of spinal nerves. Spinal nerves are bundles of axons on the peripheral nervous system, the PNS, that are connected to the spinal cord. Now, several very important points here. Each nerve is listed by the letter for the vertebral group and a number. Each spinal nerve is identified by its association with adjacent vertebrae. Now, the cervical spinal nerve C1 passes between the skull and the first cervical vertebrae. Since there are only 7 cervical vertebrae, there are actually 8 cervical spinal nerves. The remaining vertebrae are listed by the superior vertebrae. So what we're looking at here is C1 through C8. Then the next vertebrae would be obviously the thoracic. So when we're talking about that nerve, it would be T1. And then you go T1 to T12. L for lumbar, 1 through 5. Now the S, 1 through 5, remember that's the sacral, okay? And then you have the small coccyx, and that's going to be labeled CO1. That's the coccygeal nerve. For structural concepts, I want you to get some of the important points immediately because this is going to be extremely helpful down the road. We have a cervical enlargement. This is an enlargement of the spinal cord at the cervical region. Now, this is due to the innervation of nerves for the shoulder and upper limbs. You're going to have a similar enlargement that's referred to as the lumbosacral or lumbar enlargement. This is an enlargement of the spinal cords at T11, T12 region, and this is due to the innervation nerves for the pelvis and the lower limbs. The spinal cord doesn't go all the way down to the bottom to around the coccygeal area in the sense as a large cord or mass. Actually, what happens is it tapers off. This tapering off is referred to as the conus medullaris. It's a tapered, conical shape of the spinal cord. Now, this is inferior to the lumbar enlargement. It occurs at L1 or L2. Now, what happens there is as you look below the conus medullaris, you're going to see what appears to be a lot of smaller nerve roots or nerves themselves. And this is the cauda equina, which is translated roughly horsetail, because it looks like a horsetail. And this is the site where the spinal cord mass ends and you become a collection of various nerve roots. Occurs roughly at L2 and continues basically from L2 to S5. The filium terminae, this is a thin strand of fibrous tissue that extends from the inferior tip of the conus medullaris to the second sacral vertebrae. This provides a longitudinal support to spinal cord as a component of the coccygeal ligament. What I'm basically saying here is it is the filium terminae that doesn't allow the spinal cord to kind of bounce around inside of the vertebral foramen space. Rather, it helps in anchoring it so it doesn't shift much. Now, if you move forward here, you'll see this. Here we have C1 through C8. Here we have the cervical enlargement. Remember that that's going to be taking in and sending out nerves. They're going to handle basically the shoulder and the upper limb. T1 through T12. In the midst of that, you're going to have the lumbosacral enlargement. And these nerves are going to come down and go down into the lower limbs. The spinal cord will begin to form sort of this blunt end called the conus medullaris. Now, notice we've had cervical spinal nerves, thoracic spinal nerves so far, the lumbar spinal nerves, and then what happens is you have the inferior tip of the spinal cord. That's the end. Now what you have is a whole series of nerves coming out, and they look like more finer filaments. They're really the cauda equina. Now, you're still having them come out of the different vertebrae, the lumbar spinal nerves, the sacral spinal nerves, and then again CO1, okay, which you write out here. You have also an attachment called the filium terminae, which comes all the way up and attaches to the inferior tip of the spinal cord, okay? Remember the sacral spinal nerves are here, and that's S1 through S5, okay? Now, as we said, the spinal cord is divided into 31 segments, and there are the numbers there: cervical 8, thoracic 12, lumbar 5, sacral 5, coccygeal 1. What we're going to do is we're going to start looking at the internal structure of the spinal cord. You have gray matter, and that is consisting of unmyelinated axons, cell bodies, and neuroglia. This kind of forms somewhat of an H shape in the inner part of the spinal cord, whereas the rest of the gray matter is completely surrounded by this white matter, and this is consisting of myelinated axons. These are outside of the gray matter, and it's actually a reverse of the brain. See, in the spinal cord, the gray matter is on the inside, the white matter is kind of on the outward side, but in the brain, it's the gray matter is on somewhat the outside, and all of the interconnections inside are heavily myelinated, and so all the white matter is on the inside of it. You know, and gray matter is on the outside. Now you're going to notice some other very significant structures here for the spinal cord. The posterior medial sulcus, this is a shallow longitudinal groove on the posterior, that is the dorsal surface of the spinal cord. The posterior root itself contains axons of the neurons whose cell bodies are in the posterior root ganglia. Now, when we talk about the posterior root ganglion, they contain the cell bodies of the sensory neurons. Okay, so this is the afferent pathways coming up, and the axons carry information to the spinal cord. Now, spinal nerves will contain axons of both sensory and motor neurons. and they basically pass through the intervertebral foramen. You have also an anterior root, which contains axons of motor neurons that extend into the periphery to control somatic and visceral effectors. Remember, effectors, we're talking about, these are the target organs or structures that are influenced by motor neuron action potentials. We will also notice that the anterior median fissure is a deep groove along the anterior surface. So if we take a look here, this is a side view. You can see C1 through C8, T1 through T12. Now these are the nerves. Don't get them mistaken for the vertebrae. Yes, this is a thoracic vertebrae. Okay. Then you have L1 through L5. Notice that you come up with basically the cauda equina, and you also will have sort of the conus medullaris here. Now notice how these nerves will extend for quite some distance. This is up here, and yet you will get lumbar nerves that come all the way out here. Furthermore, you notice the color associations here. You've got other nerves that continue down to the sacral, and actually one that follows out by CO1. That is at the adult stage of growth and development. Okay? A couple of other very important points here. Now let's just take a look here at some of the basic structures. Posterior medial sulcus, small, shallow groove. Anterior medial fissure, very deep separation here. White matter is here, gray matter is here, and by the way, we'll get into this in a minute. This is called the central canal, where some cerebral spinal fluid goes. Now, when you have a nerve come up here, it's going to have the anterior root, which is going to have motor neuron activity sent out. So that's the efferent pathways. The afferent pathways containing sensory information will come up through, and you have the posterior root ganglion, so there their cell bodies are, and they will then extend into that posterior root, okay? And this is the anterior root here. Now, if you'll note that they show you some distinct differences as you move down the length of the entire spinal cord. Segment C3, you can see how the distribution of gray matter is and the distribution of white matter. By the time you get to segment T3, though, a lot more white matter and a diminished amount, but still important shapes, etc., for the posterior and for the anterior roots for gray matter. Then we get down to about L1, and we're almost at the end of the spinal cord itself. And notice the larger amount of gray matter here and a certain amount of white matter. What you have to understand is that white matter is not only going to be taking sensory information or motor information, it's going to send it back up to the brain, or instructions coming down from the brain. Okay? Even though we've said we're focusing purely on the spinal cord, now we have to consider that there is connections between the spinal cord and the brain. Okay. Finally, we get this little tip here, and this is segment S2. All right. And you can see the amount of, and that's taken right here. Most of this is gray matter here. There's a little bit of white matter surrounding it. Now, another very important structural consideration for the spinal cord is the spinal meninges. These are specialized membranes that surround and protect the spinal cord, very similar to what you see protecting the brain. The pia mater is a meshwork of elastic and collagen fibers that tightly are bound to the neural tissue itself. We then have the next layer out called the arachnoid matter, which is a middle meningeal layer, which includes simple squamous epithelium and subarachnoid space. Finally, the big toughie of all of the meninges is the dura mater. This is tough, outermost meninges containing dense collagen fibers arranged along the longitudinal axis. A narrow subdural space exists between the dura mater and the arachnoid space. In the subarachnoid space, you're going to have, this is going to contain what they call arachnoid trabeculae. This is a network, a network of collagen and elastic fibers that connect the arachnoid matter to the pia mater. So it's almost like pillars that kind of keep the arachnoid matter somewhat above the pia mater. And in that space is also going to be a significant amount of cerebrospinal fluid, which acts as a shock absorber and medium for transport of gases, nutrients, chemical messengers, such as nerve growth factor and wastes. Here we have a section, and you can see how the spinal cord is set up around the vertebrae. You can start right here. We'll start right here at the central canal. Around it, gray matter. You can see the nerves coming out from the anterior horn. The posterior horn is receiving, or they call it also the dorsal horn. This is receiving the sensory information. Here's white matter here, here, here. Okay? So you have the anterior root that comes up, feeds information in on sensory. You have the spinal nerve. This is the posterior root. Excuse me, I have to stay corrected here, because if you see this bump here, this is a ganglia. So what they did was they turned this around. So this would be the dorsal root. This would be the anterior root. So motor information would come out here. Sensory information would go in here. Notice that you have that deep fissure here. And let's start going through the meninges. First, the pia mater, tightly bound to all of the cord. Next, arachnoid matter. Now, if you notice, there's some fine lines here with some blood vessels, etc. That's important. But this arachnoid matter has really a space between the pia mater and the arachnoid matter. And then next after that is the dura mater. Dura mater has a small space also called the subdural area, and that area also will have some cerebrospinal fluid in it. Now we're going to get into what this little structure is over here, but we're going to move forward on this and then we'll come back to it. As you can see on the side here, this is now a side view. You can see that the nerve has information coming in and out, etc. You have the posterior root ganglia here, posterior root here, so you have sensory information coming in, and you also have the white matter around here. You have the subarachnoid space, so this would be the arachnoid matter here. Notice that the higher amount here is the actual dura mater, and outside of the dura mater is adipose tissue, which acts as a cushion here. All right. All of this is somewhat protected by meningeal membranes that are continuous with the spinal nerve connective tissue. Okay. And as you can see here, this is where you'd have motor information coming out by the anterior root. Okay. And the spacing here is going to be filled with cerebrospinal fluid. Now, these little structures here and here, this is the dentulate ligament. We're going to talk about that in a minute. Okay? And we need to talk about some of this. Now, spinal meninges are specialized membranes that surround and protect the spinal cord. Yeah, we know that. But we also have, as the result of some epidural spaces, and the spaces are more going to be down in the lumbar area, etc. This is where you get the opportunity to sample cerebrospinal fluid. You also can inject certain medication, such as anesthetics. So let's talk about this. We have the epidural space, which is the space between the vertebral walls and the dura mater. And it contains areolar tissue, blood vessels, and adipose tissue. Now, when we talk about a spinal tap, it's also known as a lumbar puncture. This is a method to safely extract cerebral spinal fluid, and to inject anesthetics to create what we call a spinal block, which means at the point in which you give the injection, from that point downward, there's not going to be any transmission of pain or discomfort, etc., going up to the brain. This is excellent for some individuals that have to have an epidural block to assist, let's say, to reduce the pain for delivery. I actually saw this done in surgery at one point, and when the anesthesiologist had properly put the needle in, you could start seeing the dripping out of CSF. It looks somewhat like water. It's clear. And then he was able to inject in there a lidocaine xylocaine mixture. Now, he was doing that because the patient had to have hip surgery, was in extreme pain, there was an injury, etc. You have to think about this from another perspective. Why do they do it down there? Because if they did it higher up, you have too much of a risk of actually having that needle puncture and damage the spinal cord. Okay? So as long as you get into the subarachnoid space below L2, and that's really inferior to the conus medullaris, you got no problem. You're going to notice in a second, I'm going to show you some cadaver pictures, but there's a really cool part of connective tissue that will prevent lateral movements of the spinal cord. And this is called the denculate ligaments. These are basically extensions of the pia mater. Now think about this. We've got prevention of longitudinal movement by the terminae filium. Okay? And now you've got lateral movement prevention by the denculate ligaments. So here is a cadaver, a dissection of the spinal cord. You'll see the anterior medial fissure. You'll see this really close up. This fine tissue here is the pia mater, very tight. But what you see here, these attachments here and here, are the denculate ligaments. You have then the spinal cord roots, and they divide into kind of like a fan. They form sort of these rootlets going into the cord. You have the posterior root. You have the anterior root. They cut back and reflect it a little bit, and you can see that arachnoid matter. Mind you, that space right between the arachnoid matter and the pia mater is the subarachnoid space where there would also be cerebral spinal fluid. Okay, and furthermore, they did some cutting and reflecting back. All of this is the tough dura mater that you see, and so therefore, this space right here, the subdural area, would be an area where also you would have CSF. Okay, now here's an X-ray that allows you to see. Here's the solid spinal cord, and then you can see what appears to be thin lines in between. These are the separations. So you can see the individual nerve rootlets. This is the cauda equina. This photo is taken down in the lower part of the lumbar, going actually into the sacral area of the spinal cord. Now, let's get one more point here. This is where you're going to do the lumbar puncture. And what you do, physicians are trained in this. You have the dura mater right here. You got the epidural space right here, but you've got the body of the third lumbar vertebrae. And so what they do is they feel down to find the lumbar vertebrae. You do have to keep in mind there is still a slight risk of damaging a cauda equina, a fiber, but that's in the subarachnoid space here. So this is all open space. So they put a needle puncture with the tip in the subarachnoid space, and you know that you've hit it right because immediately at the Luer lock point at the end of the needle, you're going to start seeing it drip out liquid, okay? And that's going to be cerebral spinal fluid. Now, gray matter integrates sensory and motor function. The white matter carries information. Remember, we've got to have it white matter because myelination enhances the speed of action potentials being traveling, and that's what we want. The structural organization of the gray matter, we have projections of the gray matter towards the outer surface of the spinal cord. These are called horns. You have several of them, and yes, you need to know these. The posterior gray horn contains sensory and visceral sensory nuclei. Keep in mind, when I say sensory, for example, did I step on a tack? Did I get a bee sting? Something like that. On the exterior, but also the interior, visceral. I basically have my belly rumbling, or I've got cramps, or something else that occurs, but it is internal in the organs. Lateral gray horn. This is located only in the thoracic and lumbar segments. And the reason being is that it will contain visceral motor nuclei, which is involved with the autonomic nervous system. The anterior gray horn contains somatic motor nuclei, and these will be involved in movement and control in the skeletal muscle area throughout the body. Okay, and we have what they call the gray commissures. Now, these are located posterior and anterior to the central canal. Think about this little bridge between the two horns, one left, one right, and in the middle of that bridge, they put a little central canal. So what you have are these thin areas that still allow for connection from one side to the other. And these are the gray commissures. And basically that allows you for cross communication or contralateral reflexes, etc. All right, because you've got cell bodies connected on one side that will communicate with cell bodies on the other side of the gray horn. So here are the gray commissures, here and here. Here's the central canal. So if I want to have some cells here communicate with cells to the other side, they're going to have their axons and perhaps other structures communicate through this area here called the gray commissures. This is the posterior medial sulcus. This is the anterior median fissure. You can see some of the remnant of the meninges here, the dura mater and the arachnoid matter, but it's kind of fragmented here. The pia mater is just sort of lined here, and you can see a little bit better here. Now this is an anterior view of the spinal cord, so the posterior gray horn is here. The anterior gray horn is here, so the anterior is going to send out motor information to, let's say, the skeletal muscle structures. The lateral gray horn here is going to be found only in thoracic and lumbar, and that is going to be controlling autonomic functions for the sympathetic autonomic nervous system. All right. The posterior gray horn is bringing in, is receiving sensory information here. Okay. Now, when we look at the functional organization of the gray matter, we have cell bodies of neurons that are organized into functional groups called nuclei. We have the sensory nuclei. They receive and relay sensory information from the peripheral receptors. We have motor nuclei, which issue motor commands to peripheral effectors. Peripheral effectors, remember, any effector is outside of the CNS, might be muscles, might be glands, etc. The structural organization of the white matter. This is where we find the white matter on each side of the spinal cord divided into columns. We're going to talk about these. Now, when we use the term tracts, this is each column is divided into a bundle of axons that are uniform in information that is transmitted. They're uniform in diameter, in myelination, and propagation speed. Now, the posterior white column lies between the posterior gray horns and the posterior median sulcus. So here is the structures that we see here. We have, of course, the posterior root that brings in sensory information, both somatic and visceral. Okay. Now, you can put a dotted line right through here to get an idea what's what. So the posterior gray horn also goes by the dorsal gray horn. The lateral here is going to be purely involved with visceral, so that's going to be mostly autonomic nervous system. The lower part is somatic, That's going to be somatic motor, and so that's going to be stuff that you have conscious, or it's going to be involved with skeletal muscle primarily. Okay. Notice that you have these columns, these structures here of the white matter. We're going to get more into those details in a minute. When we talk about the lateral white column, this includes white matter on either side of the spinal cord. Anterior white column lies between the anterior gray horns and the anterior median fissure. What are the functional organizations of the white matter? Well, you're going to have ascending tracts. These are going to carry sensory information to the brain. We're going to get into the reflexes and all that other stuff in a bit, but kind of think of it this way. If I step on a tack, I don't have it suddenly go to my brain and go, oh, I just stepped on a tack. Guess I got to pull my leg away. No, that's all on the reflex. But you still have sensory information going to the brain for you being aware of, ouch, ouch, I stepped on a tack, ouch. But you've already had the reflex fire off, so you pulled your leg back, etc. We have also descending tracts, which carry motor commands to the spinal cord from the brain. And in some cases, these descending tracts may not come purely from the brain as well, especially when you have a reflex that's purely spinal. The organization of the tracts in the posterior white column, they contain ascending tracts that carry sensations from the limbs and the trunk. So here we see this. We have the lateral white columns here, the posterior white columns here, and then we have the anterior white columns here. Okay? To help you to understand this, here is the information you're passing out on the anterior horn. And the motor nuclei include the trunk, the shoulder, the arm, the forearm, and the hand. This is the organization of tracts in the posterior white column, though. Okay? We've been dealing with motor nuclei. Now we're going to deal with the white column. So here you have leg, hip, trunk, and arm. All right, so everything is set in a specific pathway. You're going to see how this relates to some of the circuitry shortly. But here's something to help you to think about. If someone gets a cut, but it's only a transection that's halfway. So let's say they have a cut and there's an injury to the spinal cord right here. They would still have sensory information coming in here, but they would no longer have motor output for these particular structures. If, let's say, the cut went from here to here. Everybody clear on that? If I go over and I want to have the information come down or go up to the brain, and I have a cut here, what we've got is a serious issue of I don't feel anything. Now, you can still probably have motor control of these same structures, but you will not have any feeling coming up to, for example, the brain. This doesn't always happen. You have sometimes a mixed medley of spinal injuries, etc., and sometimes you have complete transection or cut of the spinal cord, but sometimes it's not completely there, and it takes time for the spinal cord to recover from the initial shock of the trauma, and then you can start seeing where you still have spinal function, both from a sensory and a motor perspective. Now, spinal nerves have a similar structure and distribution pattern. Spinal nerves contain connective tissue, axons, and blood vessels. Okay. We have to consider the layers of the connective tissue. Some fibers also have myelin sheaths. Now, when I say fibers, now you got to keep in mind something here. This is not necessarily cell bodies. This is usually pretty much axons. Okay, if you remember previously, I said you can have axons as long as 3 feet or more, a full meter. And yeah, that axon from your toe that you just stubbed carried information back all the way to the spinal cord, which is a considerable distance. When we look at these connective tissue structures, the first one is the epineurium. This is a layer of connective tissue that surrounds the entire nerve. Inside a nerve, you will have these nerve bundles called nerve fascicles. You have some connective tissue there that isolates fascicles within the nerve, and the isolating connective tissue is called the perineurium. Then we have connective tissue that basically surrounds individual nerve fibers, and that's called endoneurium. When we talk about a branching in nerves, we talk about the term rami. If it's singular, it's ramas for branch. So let's show you a little here. Here is my nerve. Notice inside the nerve you will have also arteries and veins, and you will have fascicles. So let's go from the outside in. You have the epineurium here, and now notice that the fascicles don't take up all the space, so you have to have something that's sort of like a filler in between these fascicles, and that is perineurium, okay? As well as this lining here is perineurium. Now, as I said, fascicles of nerve fibers have this collection here of perineurium, and then we get to the individual nerve fibers. Now, this one is myelinated. Here's the axon. Here is the Schwann cell that provides the myelination, and then outside of it is endoneurium. So these are the connective tissue layers of a spinal nerve. As I mentioned to you before, rami is a branch of a nerve. We're going to go through some of these rami that are extremely important. The dorsal primary ramus supplies the deep back muscles and skin on the dorsal surface of the trunk, so on your back, okay? The ventral primary ramus supplies the structures on the limbs, the skin along the lateral and ventral surfaces of the trunk, and skeletal muscles except the deep back muscles. So the ventral primary muscles would include, of course, your sides, the skin along what we call the lateral and the ventral surfaces, so around the belly, things like that, as well as on the limbs. Then we have a structure that's called the rami communicantes, and this is present only in T1 through L2. These rami contain axons from sympathetic autonomic nervous system neurons. Just so that you understand what ANS means, that refers to the autonomic nervous system. This is a little bit different. These spinal nerves exist only in the thoracic and upper lumbar segments. They carry motor output from the sympathetic division, that's basically your fight or flight, of the autonomic nervous system. We'll get more into the autonomic nervous system in chapter 14, but just get this down now, and it's going to help you down the road. Here, of course, is the posterior ramus, the anterior ramus. So you've got our different branching outs. You have a spinal nerve, the posterior root ganglion, the posterior root. So basically, this is the sensory information coming in. This is the anterior root. So this is the motor information coming out. Now, one of the weird things, it seems weird, but it's important to understand, is that you have this rami communicantes, and you're going to have this information going back and forth, and then may go through this autonomic nerve. The sympathetic ganglia are present, particularly in the thoracic and in the early part of the lumbar nerves that are, the ganglia is really outside of the spinal cord itself, outside of the vertebrae, because this is going to handle autonomic nerve impulses, okay? Speeding up heart, slowing down digestion, speeding up respiration, basically the fight or flight responses that we deal with. All right. Now, the other interesting thing you have is dermatomes. These are divisions of the sensory cutaneous regions of the body innervated by a single pair of spinal nerves. So what we're saying is that we can map out where the spinal nerves innervate for our sensory, basically the sensory map of our body. Now, adjacent dermatomes on the trunk will have some overlap, and variations of individuals does occur. The only one that's unique is that C1. It lacks skin innervation. The reason being is that the face is monitored for basically cutaneous sensation by the cranial nerve 5. That's CN5. That's Roman numeral 5 there, V. Something else to keep in mind with dermatomes. And by the way, when surgeons know this, they know this in and out, etc., because basically they know what they have to cut. And also, neurologists know this so they can get an indication of whether certain nerves have damage because of a loss of sensory information. It's like sitting there going, well, gee, doc, I mean, only part of my hand I can't feel, but the rest of it I can. Why? We'll show you that in a second. There's also an interesting point here called shingles. Now, this is from the Latin cingulum, which means girdle. Okay, here's what's going on. It's caused by the same virus that causes chickenpox, herpes zoster virus. The virus attacks the neurons on the posterior root of the spinal nerves and the sensory ganglion of the cranial nerves. Now, we're going to get into cranial nerves much more in depth next section, because cranial nerves are associated with the brain. Anyone who has had shingles, it is painful. You have a rash, it's very, very painful. It may be very prominent. And you also have blistering. And this corresponds to the area innervated by the spinal sensory nerves and the dermatome. To help you to understand this, if you had chickenpox, okay, then what happens is the virus will go into select nerves and basically hide there. Usually it shows up again when people start getting elderly. They may be immunocompromised. This sometimes happens in pregnancy. Now, to help you understand why, think about just from the perspective of a woman who is pregnant. She now has a developing embryo or fetus, which has lots of foreign proteins, contributed in part by the genetics of the father. And so her immune system does get muted down somewhat to allow for this event to occur for 9 months. All right. But when you have a reduced function immunity, and in the elderly, it happens that their immune system is much weaker than when they were much younger. Someone who is immunocompromised, and it's not just AIDS patients, you have others that have immune disorders, or they may be on anti-rejection drugs if they've had a transplant, or they may be on certain drugs that will compromise or damp down the immune system. So they treat the autoimmune disorder that's going on. The problem is it makes this person then susceptible to certain diseases, such as shingles. Also, those with cancer are most susceptible. If they're on anti-cancer treatment, it may do some damage to the immune system and may weaken the immune system. So that's why we now have these shingles vaccines, though there should be something I will throw out to you from personal knowledge, and that is it takes you 2 shots or almost 3, depending on the supplier, and you have to pace them apart, and it's difficult at times. Sometimes supplies are not always frequently available. But some of this is being alleviated because of the presence of a chickenpox vaccine. So then the individual doesn't get the chicken pox, they don't get the herpes zoster nesting into the root ganglia, the nerve ganglias. Here is looking at interior and posterior of the dermatomes. So what you can see here is where C2 is, C3. All of these are handling the different sensory inputs. Now notice down here the pinky finger. That is from T1. And that's because if you look on the back arm, you've got the T1 here coming up through and back up to there. Now, T1 comes on the front part of the arm to a point. You've got also underneath near the axial area T2. So here's the situation. If somebody says, I have no feeling in my hand at all, it is not a matter that they have one nerve damaged. This is unusual. For example, your middle fingers, the sensory input is from C8, whereas your index finger is C10, excuse me, C9, and then you have also C5 for the thumb. Now, of course, you go down into the lower part of the body, you have L1, L2, L3, 4, 5, and then you've got the sacral. On the back part, you can see we're sacral 1, 2, and then you've got 3, 4, 5, but then you've also got the lumbar that comes down on different sides here. What I'm trying to say to you is that that map tells you pretty much, there's a little variability as I mentioned before, where each of the sensory areas pass the information back up on the spinal nerves. Here's an example of shingles. It's very painful. As you can see, it comes down to the umbilicus here, along this area of the sensory, the cutaneous sensory of the spinal nerve. Now, one of the things that does happen also, just to make you aware, is that people who are under tremendous stress may get themselves immune compromised because their immune system has been pumping out lots and lots of cortisol, and that tends to reduce immune function, damps down the immune system. Okay, so let's move onward. Now, each ramus provides sensory and motor innervation to a specific region. Now remember, ramus is the branching, okay? Now the sensory information, you want to note the pathways. The posterior ramus carries sensory information from the skin and skeletal muscles of the back. Anterior ramus carries sensory information from the ventrolateral body surface structures in the body wall and the limbs. What about motor commands? We've been talking about sensory. Okay, you want to note the innervation targets. The posterior ramus contains somatic motor and visceral motor fibers that innervate the skin and back skeletal muscles. The anterior ramus, so we've done the posterior, anterior here supplies the ventrolateral body surface and structures of the body wall and the limbs. So you can see where this is going to go off. Now, by the way, what sensors are there? I mean, I don't have like an eye on my arm or anything. No, but you've got a lot of other sensory structures that play a role in providing information from the skin, from joints, from position markers. So you've got interoceptors on the back, exteroceptors, proprioceptors on the back. All of this is going to come in from the posterior ramus. From the anterior ramus, you've got exteroreceptors, proprioceptors of the body wall and limbs, interoreceptors of the body wall and limbs. All this sensory information is going to come in by the anterior ramus, and it's going to eventually get fed in through the posterior root into that somatosensory and visceral sensory nuclei here. Now, what about the interoreceptors of the visceral organs? This will also come up through. And this is going to be through a sympathetic nerve, though. This is where you have the rami communicantes, and it contributes to further sensory input here. Okay? The white ramus communicantes is a short nerve branch that carries visceral motor fibers to a nearby sympathetic ganglia. The gray ramus communicantes is unmyelinated, so it's slower. Postganglionic fiber, it appears grayish, that innervate the smooth muscle and glands. Together, they're known as the rami communicants or communicating branches. and you can see these here. What you will see is the white, which would be meaning that it'll give you a hint of basically that it's myelinated. There will be a sympathetic ganglion chain that comes up through here. This is going to be the gray ramus, and this information is going to get passed down and out because this is involving motor commands, okay? Posterior ramus coming out, postganglionic fibers, the smooth muscles, glands in the back, etc. That is going to be the part that is going to be autonomic nervous system. To the skeletal muscle in the back, that's going to be more somatic motor, okay? Same thing out here on the anterior ramus, postganglionic fibers to smooth muscles, glands of the body wall and limbs. And then also you've got, that's the visceral motor, the basically the motor fibers that come out here to the skeletal muscles of the body wall and limbs, okay? That's what you're going to be conscious of, okay? Notice that it comes out, visceral motor nuclei comes out through here, back and forth and comes down. Somatic motor nuclei comes out and branches out to posterior and anterior. Now, spinal nerves form nerve plexuses that innervate the skin, skeletal muscles, which we have talked about. I want to bring up some of the specific plexuses. Now, what is a plexus? This is really an interwoven network of nerves. Some of the spinal nerves converge. You have the anterior rami of adjacent spinal nerves. They blend their fibers, producing compound nerve trunks. What you have to understand is there are different major plexi, and they serve different parts of the body. Here's one thought. If you've ever seen on television programs, the hero gets shot, and a lot of times the shooting goes into the shoulder, all right? And everybody says the next week, he recovered, that's great, you know, Baloney. You don't want to get hit in the shoulder. You want to get hit in the shoulder because you've got lots of blood vessels and nerves, including some of the nerve plexus that will eventually pass down their fibers down into the upper limb. So let's take a look at the four major plexus. The cervical plexus, C1 through 5, it innervates the muscles in the neck and the diaphragm. Brachial plexus, C5 through T1, innervates the pectoral girdle and the upper limbs. The lumbar plexus, T12 to L4, innervates the pelvic girdle and the lower limbs. Now the sacral plexus, which is L4 through S4, innervates the pelvic girdle and the lower limbs. Also, the lumbar and sacral are often referred to as the lumbosacral plexus. Here is the lumbosacral plexus, right from here down to here, broken down to the lumbar plexus at T12 to L4, and the sacral plexus, which kind of overlaps at L5 and L4, and then goes all the way down to the last sacral. Doesn't include the coccygeal. Now you notice up here you got another brachial plexus and a cervical plexus. So you have the greater occipital nerve, lesser occipital nerve, great auricular nerve, transverse cervical nerve, supraclavial nerve, phrenic nerve. Then you have this plexus right here. Remember how I said you don't want to get hit in the shoulder? It gets shot right there. What happens? Could be possibly damage to axial nerve, musculocutaneous nerve, thoracic nerves. All of that, that's not a pretty sight. Notice that you're going to have also radial nerve, ulnar nerve. Medial nerve, remember the medial nerve? That's the one that goes through that unfortunate thing called carpal tunnel syndrome as it goes all the way down. Okay, so these nerves you're going to, yes, eventually get to know. One of the biggest ones, is your sciatic nerve. You also have your saphenous nerve coming down here. Okay. Notice how this comes together. It's almost as if several of the spinal nerves come together and separate out. Come together, separate out. Mixing and matching. So we're going to go through each one of these plexi, and you're going to have certain nerves you absolutely need to know. Yep, it's memorization time. One of the suggestions again is use index cards, maybe use a Quizlet, but whatever you have to do, you have to start getting these nerves down now. The cervical plexus innervates muscles of the neck and the diaphragm. The branches innervate the skin and muscles of the neck and extend into the thoracic cavity. They control breathing via the diaphragm. Nerves of the cervical plexus include the great auricular, which is C2, C3, the lesser occipital, C2, the transverse cervical, which is C3 to C4, the ansa cervicalis, which is C1 through C4, the phrenic, now this one's very important because it controls the diaphragm, which is C3 to C5, and then the supraclavicularis, which is C3 to C4. And here you see them right now. And yes, I do expect you to know them. You'll note, though, that a lot of these start innervating a lot of the muscles that we started to talk about in the prior chapters. Okay, so that gives you an idea where they are, what they function, what they do. The brachial plexus, which is C5 to T1, this innervates the pectoral girdles and upper limbs. Nerves of the brachial plexus, the major nerves of the arm, the forearm. That's one of the two things that you're going to be mindful of when we talk about the brachial plexus. So these include the musculocutaneous, which is oversees the flexor muscles of the arm and forearm, the sensory of the skin of the lateral surface of the arm. The radial nerve, which is the extensor, controls the extensor muscles of the arm and forearm, the sensory input of the skin of the posterolateral surface of the arm. The median, which controls the flexor muscles on the forearm and the digital flexors. It also takes in the sensory input for the skin over the anterolateral surface. And then we have the ulnar nerve, which controls the flexor digital muscles of the hand, as well as taking up the sensory of the skin medial surface. And you can see these listed right here and see the pathways. And you can see how they branch out into the hand as well. Okay, so yes, you need to know these. Now, this is where I was bringing up a point before. If you remember, we talked about dermatomes, and I said, well, gee, what about what nerve controls what? The best way to think about it is this. We talked about the median nerve. Remember with carpal tunnel, which would be about right about here? If somebody says, I have carpal tunnel, but they're talking about pain right here, I don't think so, because that's the ulnar nerve. Here is the median nerve. So on the anterior side, which you have of the hand, the thumb, the palm, basically the ring finger and the middle finger, and to a part, excuse me, the pointer finger and then the middle finger, this is the ring finger, I'm sorry, that's the pinky. If you take a look at that, what have you got? Well, if they say that they've got tingling or they've got numbness or they have pain in this area, yes, now you have pressure and problems with the median nerve. Notice also that the median nerve really controls the upper part on the posterior side for the thumb from the nail back a little bit, and then the upper parts of the posterior here. The ulnar nerve really takes care of this latter part here. The radial nerve takes care of the posterior palm surface, top of the hand surface, I should say. So this is why I'm trying to get you to understand that all of this, the nerves have specific pathways, and you can use them to tell you information of the function or dysfunction of these nerves. Let's move to the brachial plexus. And the brachial plexus C5 to T1. We were talking about the brachial plexus nerves that form from cords and trunks. When we talk about a trunk, this is a large bundle of axons from several spinal nerves. The trunks split to form divisions. Cords are the combination of divisions of these nerves. So you're going to see this particularly here. Now, what you see here is the superior trunk, and they basically color code them. So you have the anterior rami here that come together, form this brief superior trunk, and then branch out into divisions. And you can see some of the pathways come in here until they come to cords here, here, and here. And then they branch off from there, and now you have clearly the median, the ulnar, the radial, okay, and the musculocutaneous, okay? Now, the lumbar and sacral plexus innervate the skin and the skeletal nerves of the trunk and lower limbs. The lumbar and sacral plexuses arise from lumbar and sacral segments of the spinal cord. These nerves innervate the pelvic girdle and the lower limbs. This is where you're going to get into from basically the hip area all the way down. The key lumbar plexus is basically consisting of nerves from T12 to S4. So remember, that's T12, L1, 2, 3, 4, 5, as well as S1, 2, 3, 4. This is where you're going to have to know the iliohypogastric, the ilioinguinal, the genitofemoral, the lateral femoral cutaneous, the femoral, and the obturator. And you can see how these branches come together, separate out, and what you have are basically this T12 subcostal nerve. You have the iliohypogastric here, whereas next to it you have the splitting off of the ilioinguinal. You have the genital femoral, the lateral femoral cutaneous, the femoral, and the obturator. Okay. You also have a lumbaral sacral trunk right here. Now, those nerves that innervate the pelvic girdle and lower limbs will consist of the sacral plexus, which is L4 to S4. These include the superior gluteal, inferior gluteal, the posterior femoral cutaneous. Now, the sciatic is the largest and the longest nerve in the body, and then you have the pudental. So as you can see here, look at the huge, thick area of the sciatic. You have the pudental coming down here. Notice that you've got all of this coming in from the lumbral sacral trunk, S1, 2, 3, and 4. Notice CO doesn't really play a role here. But you do have the superior gluteal, the inferior gluteal, the posterior femoral cutaneous, the pudental, and of course then the sciatic. Okay? I do expect you to have a good understanding of what these nerves, where they basically place themselves. If you've gotten the skeletal muscles down, you should be able to see how a lot of these play a role. And by the way, anytime you see the word, of course, cutaneous, you know that it's taking in or involved with the skin over a particular area, in this case over the perineum and the posterior thigh and legs. That's why it's posterior femoral. And you can see as you move down here, I expect you to know not only the iliohypogastric, ilioguinal, genital femoral, lateral femoral cutaneous, and the femoral and obturator, the superior gluteal, the inferior gluteal, the pudendal, but then the posterior femoral cutaneous. You can see where they had to cut that. Sciatic, and now we move down into the saphenous nerve, the common fibular nerve, the superficial fibular nerve, the deep fibular nerve. Now behind it, you see where the sciatic goes downward, branches off into areas such as the common fibular nerve here, and then we have the sural nerve, which notice that goes on the outside of the foot, and yet it innervates basically most of the bottom of the foot. That's where it's playing a role. It has a little bit of input on, excuse me. Yes, I said the sural nerve, and what we're talking about the sural nerve here is on the back side of the foot going down on the small toe. So what you've got really is innervation and control on sort of the outward side or the lateral side of the foot here. The tibial nerve is the one that comes all the way down and basically takes up all the sensory and motor activity here on the bottom of the foot, on the plantar part. That's going to play an important role when we talk about certain reflexes. We'll get into that. The top part, the fibular nerve here, if you follow the fibular nerve, it will go down. It will be on somewhat the outside, but it basically covers the top part of the foot for the most part. You also have on the inseam here, on the medial side, the saphenous nerve that's picking up sensory input, etc. Now, we have to get into an area called neural pools. And I know that this gets into sort of processing. What are we talking about? Well, neurons do not function individually. They pass information along, and the interaction of them provides further details and information down the road. The central nervous system neurons are grouped into neural pools, which form neural circuits. A neuronal pool is a functional group of interconnected neurons. You're going to see that a lot in the spinal cord. A neural circuit is a pattern of interaction of neurons in a neural pool. There are common circuit patterns, and these include divergence, the spread of information from one neuron to several neurons, or from one pool to several pools. Think about it this way. It's as if you go up and you pass information to two people, and then they turn right around and pass it to two people more. And they go turn around and turn it to two people more. And what you're going from is information from 1 to 2 to 4 to 8 individuals. Similar. Then we have what's called parallel processing. This occurs when several neurons or a pool of neurons process the same information at the same time. Divergence must occur prior to the onset of parallel processing. Okay? So you've got to have this spread out before it can be brought together. Serial processing, almost like, one to the next in a step-like manner. So this is information that's relayed from one neuron to the next in a stepwise manner. Remember that information is going to be carried by action potentials. But we're going to move through certain patterns so that we can then understand how reflex circuits work. And we also have what's called convergence. Several neurons synapse on a single postsynaptic neuron. Several patterns of activity can have the same effect on the neuron. Reverberation is the positive feedback loop where a collateral, in other words, that's a branching part of the axon, branches and extends back to the presynaptic neuron as a source of impulse or further stimulation for that presynaptic neuron. The most complex circuits occur in the brain. The simplest circuits occur in the peripheral nervous system and spinal cord and control autonomic reflexes. Huh? Here, let's go through this. I have one, then I have two. They pass on this information to three others and three others here. So basically it's like a pyramid. The first one activates the next set and they pass it on to other neighboring ones. Now, parallel processing is when they're all getting the same information and they pass it down to another. Serial processing is just a step-by-step neuron A to neuron B to neuron C, etc. Just one straight line. Okay? Convergence is when you have all of these nerves chattering to this one postsynaptic nerve right here. And they're passing down all of their action potentials at the same time, which leads this one to fire off the action potentials downward. So think of it as sort of a funnel right here. Finally, we have reverberation. Now take a look at this. Here I have the presynaptic neuron, passes on information to another neuron. Then this neuron will pass through, but remember with collaterals, the action potential travels here, goes down on that branch as well as this branch. So once this information passes here, it will feed back to this presynaptic one again and continue this cycle. Meanwhile, this postsynaptic neuron goes down and feeds information to a neighboring postsynaptic neuron. Okay? This is where we get into reflexes. They're essential for homeostasis. Okay? Brings us back to chapter 1. How do we manage the basic functions internally despite changes internally or externally? We have to have systems that you don't even have to think about, but you know you will act on. It's automatic. You don't have to sit there and ponder it for a half hour. Should I pull my foot up after I've stepped on a tack or not? No, it's bingo. I stand it and I'm jumping around and I just hurt my foot and something like that. Now they're rapid, they're automatic responses to specific stimuli. Now the route of the reflex arc includes the following: the stimulation of the sensory receptor, the activation of the sensory neuron. So by activating it, what's going to happen? You're going to send sensory information up afferent pathways to the information processing area in the CNS. Remember, it can be either spinal cord or brain or both. From there, the CNS will send out activations of a motor neuron. They will send out motor action potentials down efferent pathways, and you will generate a response of a peripheral effector. That could be a muscle, that could be a gland, that could be my heart races, that could be I jump up and down on one leg because the other leg I hurt by stepping on that tack. Okay? Now, reflexes can be classified according to their development, the nature of the resulting motor response, the complexity of the neural circuit involved, and the site of information processing. So let's go over some of these characteristics. When I say development, is this learned? Or is this something that basically has been pre-programmed in since I was a fertilized egg? This is where we get into innate. It results from genetically or developmentally programmed neural connections. Now we have also acquired reflexes. They're conditioned. They're rapid and automatic, but they were learned. We were not born with them. and they're enhanced by repetition. Okay? When you played dodgeball when you were a kid, you didn't have that programmed into your head. Well, avoid the ball so I don't get beamed with it. No. But after playing it more and more and more, what happens? You developed learned responses. Duck, etc. Okay? The same thing. Nature of the response. Is it somatic reflexes, which involve involuntary control of skeletal muscles? For example, the withdrawal reflex. I put my hand over something hot, I pull it right back. I didn't even have to think about it. I didn't have to sit there while my hand's burning on the grill and go, I think I should put it away, pull it away. No, it was involuntary. I didn't even think about it. It just happened. Skeletal muscles. I pulled my hand away. There's also visceral reflexes. They're automatic reflexes, autonomic reflexes. They control or activate smooth muscles, cardiac muscles, glands, or adipose tissue, or several things. You ever do the reflex where you're in a darkened room and then you turn on the light and your pupils change size? Well, there's smooth muscles in the iris, and as the light increases, the iris, certain muscles will contract and they will reduce the aperture, the size of that pupil. Now that's a visceral reflex. It's automatic. Also, we look at another characteristic, which is the complexity of the circuit. We're going to find out about monosynaptic reflexes and polysynaptic. Mono obviously is one, poly means many. So how many synapses are involved with this reflex? A monosynaptic involves the simplest reflex arc of one sensory neuron and one motor neuron. Polysynaptic reflexes involve at least one interneuron as well as a sensory and motor neuron. Now, one of the other characteristics is the processing site. Okay, spinal reflex, the interconnections occur in the spinal cord. Usually these are simple segmental reflexes. A to B, B to C, C to D, that's it. Intersegmental reflexes involve multiple segments of the spinal cord. Now let me clarify that with the interconnections in the spinal cord. Spinal reflex can occur just at one particular area. Intersegmental means that you may have the pathways go up somewhat along the spinal cord, then back down, then up, then back down, around, etc. Cranial reflexes, this is where you have important interconnections and processing occurs in the brain nuclei. When we have clusters of cell bodies outside of the brain in the spinal cord or next to the spinal cord, we call them ganglia. When we have a series of cell bodies, just cell bodies, that are in the brain, we call them nuclei. Now, usually when you have brain nuclei, they're surrounded by white matter, as we will see in the subsequent chapter. Let's go through the spinal cord, the reflex first. Stimulation here, I put my hand down and the stimulus is the tack and I have the receptor fire off, activation of the sensory neuron. This passes up a sensory neuron. You're going to have also the posterior root ganglion. It goes over into the posterior horn. So now you have information processing at the CNS. In this case, you see that white neuron there? Well, that one is an interneuron and passes information to the higher centers of the brain, but it also passes over information to the motor neuron. The motor neuron passes information, motor impulses, to a specific area of skeletal muscles, the effector, and that's where I pull away. Okay? That's where I'm pulling away from the initial stimulation. It's a painful stimuli, okay? So, as I said before, here are the characteristics you need to be mindful of. When we talk about reflexes, is the development innate or is it acquired? Is the nature of the response somatic reflexes or visceral? Is the complexity of the circuit monosynaptic or polysynaptic? Is the processing site going to be spinal reflexes or cranial reflexes? So let's take a look at some of these reflexes right now. First off, a stretch reflex is a monosynaptic reflex involving stretch muscle spindles. The stretch reflex, this is where you have a monosynaptic reflex that automatically regulates the skeletal muscle length. Now, a muscle spindle is a structure inside, or stretch muscle spindle is a structure inside of a skeletal muscle that basically feeds back information on the particular length or contraction of the muscle at the time. You've seen this very commonly. Doctor comes in with a small rubber mallet, the medical hammer, hits the patella, the patella tendon, and you have the patellar reflex, otherwise known as a knee-jerk reflex. What happens there, we're going to show you in a minute. Basically, he causes a stretch that occurs on the tendon. It's relatively monosynaptic, so you have a sensation that feeds back to the spinal cord, and then the response is that the muscle in the leg will cause the lower part of the leg to jerk upward. Okay? You don't have to think about it. You don't have to know about it. So the stimulus is increasing the muscle length by tapping of the patellar ligament with a reflex hammer. The information processing is in the spinal cord, CNS. The motor neuron is activated. The response is a contraction of the stretched muscle, that brief kick. Note, the reflex travels fast due to the action potentials traveling on myelinated large diameter fibers. Okay, so here we go. Pop, little tap here on this patella that stretches the muscle. That's the stimulation of the receptor. The activation of the sensory neuron, there's this spindle in here that gets stretched. This information is passed up through the posterior root ganglia. Monosynaptic, meaning that you only have one synapse right here, sensory to motor. Okay? This is all processed in the CNS, in this case, in the spinal cord right there. As a result of the stimulus, you have activated the motor neuron, which will innervate this particular muscle, okay, the quadriceps muscle, and it will cause a contraction, and that causes the response, the kicking upward. Okay? By the way, you sit there and say, so what does he do this for? Simple. He's doing a simple neurological assessment of whether there is a problem. If there's no response, that may hint that there may be further problems with the function of the nervous system. Now, muscle spindles, as I mentioned, these are sensory receptors. They're embedded inside muscles, which provide stretch or length information. Muscle spindles contain a bundle of tiny specialized skeletal muscle fibers called intrafusal muscle fibers. Now, both sensory and motor neurons innervate each interfusal muscle fiber. Stretching the central portion of the interfusal fiber distorts the dendrites, stimulates the sensory neuron. This stimulates the motor neuron to increase muscle tone. Compression of the central portion inhibits the sensory neuron and subsequently reduces motor neuron activity and decreases the muscle tone. Many stretch reflexes are postural reflexes to help maintain normal upright posture. Here is my interfusal fibers, and here's where you've got some interesting information here. Look, these are the regular skeletal muscle fibers. These are the interfusal fibers. Here is an axon of the gamma motor neuron in the CNS. So it's going to innervate right here. Here is also another gamma motor neuron innervating the muscle fiber. This is all muscle now. So where's the sensory? Right in the middle. This carries information to the CNS. Now the dendrites of the sensory neurons spiral around the interfusal fibers in a central sensory region. Okay. In other words, what this is sort of part and parcel of what we talk about when we talk about proprioception, extra receptors. When we talk about basically, how do I know my arms are stretched out? How do I know my arms are going forward? All of this information is passed on because the muscles are either going to be stretched or relaxed. Okay? Now, when I have this resting length, I end up with a certain frequency of action potentials. Remember, we talked about this. Action potentials, maximum you can have per second, 500. So what do you have? You have the information coded in the number of action potentials per second. Effect on the skeletal muscle, normal muscle tone persists. If I stretch them, muscle tone increases, as you notice that the APs are increasing. If I'm compressing them, the muscle tone decreases. First here on the stretching, the muscle tone was increasing. Down here, the muscle tone was decreasing. And notice how the pattern of APs decreases. Okay. Now we're going to get into two other really, really important ones. Withdrawal reflex and the crossed extensor reflex. These are polysynaptic reflexes. The withdrawal reflex is a reflex move, moving the affected part of the body away from the stimulus. Okay. The strongest withdrawal reflexes are triggered by painful stimuli, but these can be triggered by stimulation of touch or pressure receptors. Okay. The flexor reflex is a form of withdrawal reflex that affects the muscle of the limb. Usually this is to repel the limb from the stimulus. Now we're going to get into another concept, reciprocal inhibition. Reciprocal means it works both ways. A polysynaptic reflex, where a flexor is activated and the antagonist, the extensor, is inhibited or relaxed, or vice versa. Now, I want you to understand something too. There's going to be a term probably used here, ipsilateral, contralateral. Ipsilateral, ipsi means same. So, same side, ipsilateral. Contralateral means opposite side. So what happens when you have withdrawal reflexes and crossed extensor reflexes? Well, we're going to show you that. Stretch reflexes and withdrawal reflexes are all ipsilateral reflex arcs. The reflex arc on the same side. The sensory stimulus and the body response are on the same side of the body. Painful stimulus. Ouch! And I pulled my arm back. So what's going to happen here? Now this is all on the same side. Okay? You touched a hot pan. The pan was very, very hot. And the painful stimulus goes up through the posterior group. Now look, here's a couple things. This is polysynaptic. Why? Synapse here, synapse here, synapse here, synapse here. At least 4. But you got to keep in mind something too. You're going to have information pass up other segments of the spinal cord, and some of it may actually go to the brain. Okay. What's going to happen here is you have to do 2 things. For the arm to basically pull away, you have to have the extensors inhibited, the flexors stimulated. Okay? If you couldn't get either of them stimulated or inhibited, that hand could literally be in the same place and burning now. Okay? So sensory information is passed up, and now you get 2 motor inputs. One of them is inhibitory to the extensor muscles, and this is called reciprocal inhibition, whereas the flexor is stimulated. Okay? So the hand gets moved back. But this is all on one side of the body. Now we get into the crossed extensor reflex, and it involves a contralateral reflex arc, contra opposite. You're going to have an additional motor response occurring on the opposite side of the stimulus. This is where you're going to have a polysynaptic activity in the spinal cord. Usually, when you have this, it is a painful sensory input. That's on the one side. The motor response on the same side, you're going to have withdrawal. One limb extensor is inhibited, the flexor is stimulated. The opposite side, you're going to have an extension, not a withdrawal. The opposite limb, you have the extensor stimulated and the flexor is inhibited. And this is where you need to review these. Let me give you an example. I stepped on a tack. Ouch! Okay, so here's the sensory information going up to the spinal cord. Now here is where you're going to have this polysynaptic 1, 2, 3, 4, 5, 6. What's going to happen here? You're going to have information obviously going up other segments of the spinal cord and may go into the brain. Sort of like a realization afterwards. But what happens? You're going to take the initial same side and have that basically withdrawn. You're going to have the flexor stimulated to pull the foot away from the painful stimulus. The extensor is going to be inhibited. That's the same side. What about the other side? Well, look, if I don't stand on one leg, I'm going to fall over. So you have contralaterals that go across, passing from one side to the other. They will act here so that the extensors are stimulated. So you straighten out, you dance on one foot, yelling, ouch, 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 ouch. And your flexors are inhibited. You got to inhibit these guys so that you can stand straight and put all the weight on basically one body side. That is the cross reflex that you're seeing. And this is all coordinated. You don't even think about this. It's the information that gets passed up to the brain where you kind of go, oh, wow, I stepped on a tack. Or it's 3 a.m. in the morning and my kid left some Legos out and I stepped on them and I'm half asleep and I'm like bouncing around going, ouch. Couple of things to keep in mind. Properties of polysynaptic reflexes, they involve pools of interneurons. Remember all those pools that we went over earlier? That's where they're playing a role. They involve more than one spinal segment. They involve reciprocal inhibition, and they have reverberating circuits which prolong the reflexive motor response. You don't want to put your foot back down on the floor yet until you're away from where that tack was. And several reflexes may cooperate to produce a coordinated, controlled response. Now, a couple of little other details, and this we get into some more clinical applications here. The brain can inhibit or facilitate spinal reflexes. Also, reflexes can be used to determine the location and severity of damage to the central nervous system. There's a term, reinforcement. This is the facilitations of motor neurons involved in the reflexes. We have the Gendrastic maneuver. This is a distraction technique, requiring the patient to lock hands at fingers and try to pull hands apart while a light tap on the patellar ligament, resulting in enhanced patellar reflex response. Now, there are other reflexes used to test spinal cord segments. Many are used in physical exams. We have the biceps reflex, the triceps reflex, the ankle jerk reflex. Okay? Now, if you don't have the opportunity in the lab, you can possibly do these, and I will try to include some video of some of these reflexes in both lab and in lecture videos. Take the time to review. Let's go over one that's very important, and it's a bit of an unusual one. It's called the Babinski reflex. This is used for infants under the age of 2. Now, hear me out first. Myelination is not complete till about age 2. When you are fully myelinated, this ends in a positive reflex, and only adults with motor neuron damage demonstrate this reflex. For infants, the toes are extended. For adults, they're going to be curled. This is where you get into the plantar reflex, otherwise known as the negative Babinski reflex. When stroked on the sole of the foot, the patient's toes are flexed. They curl inward. Now, if you do this for an infant under the age of 2, instead of getting the curling, they will extend out. The toes will kind of be out there. But if you have an adult that demonstrates that, that is indication of motor neuron damage. Another one, the abdominal reflex. This depends on facilitation, not inhibition. Light stroking of the skin of the abdomen causes a reflexive twitch of abdominal muscles moving from navel to the stimulus site. So, do a little bit of almost like a light stroking here, and you're going to have a reflex over here. The ankle jerk reflex is basically using the reflex hammer on the calcaneal tendon. And what will happen is you will have the foot extend downward, okay? Sort of a plantar reflex. If you do the tendon right here for the biceps reflex, you'll have the same situation, or the triceps reflex here on the tendon here. You'll have the arm extend outward, so you'll have an extension here. With the biceps one, you'll have a flexion here. Notice the arrow here. Babinski reflex, we just go and try to use the hammer gently here, and you have all the toes spread out. That's a positive Babinski. That's expected for children under the age of 2 because they have not completed myelination. Okay? When myelination is complete, and normally you'd see this in adults, you're going to get a plantar reflex where they're going to curl their toes downward. All right? Now, I would encourage you to try to review some of these. There are a variety of them, and they give you an idea of basically the nerves that are involved, the normal response, the reflex involved, and how to do the stimulus. Okay? I encourage you to take the time to do the superficial reflexes and the stretch reflexes. And we're just done. Congratulations, that's great. Now, I do encourage you with this chapter to peruse chapter review outline on pages 465, 466, to complete review questions on pages 467, 468. Complete the review sheets. Now, again, these are review sheets for you, not for me. I don't need these handed in. These are just for you to review and see if you really understand the material. They'll be on pages 454 and 464. The next chapter we're going to explore is going to be chapter 13. This involves the brain, cranial nerves, and sensory and motor pathways. And I hope you have a great day.